Quest for Quality is an educational production of IPRO. Opinions expressed reflect the views of the speaker only and not those of any company or agency. This podcast is intended for private, non-commercial use only. Please visit qi.ipro.org to read our full disclaimer and terms and conditions.
Welcome to the Quest for Quality, the podcast of the IPRO Quality Innovation Network Quality Improvement Organization, or QIN-QIO. I'm Teresa Lubowski, and I'll be your host today. Since the COVID-19 pandemic began, the QIN-QIOs across the nation have been focusing on helping nursing homes and long-term care facilities increase COVID-19 vaccination rates and more recently encourage the use of therapeutics to treat active COVID infections. Today, it's my privilege to have a conversation with Dr. Michelle Bellantoni. Dr. Bellantoni is an associate professor of medicine in the Division of Geriatric Medicine and Gerontology at the Johns Hopkins University School of Medicine. She is also associate director for post-acute and long-term care at the Johns Hopkins Bayview Medical Center and medical director of the Johns Hopkins Bayview Specialty Hospital Program. Dr. Bellantoni received a Bachelor of Arts degree from the University of Pennsylvania and medical degree from the Johns Hopkins University School of Medicine. She completed internal medicine training at the Johns Hopkins Hospital, a fellowship in geriatric medicine at Johns Hopkins, and a 3-year research fellowship at the National Institute on Aging in the Division of Endocrinology and Metabolism. Dr. Bellantoni, welcome, and thank you for joining us today.
My pleasure. Thank you for having me.
Okay, I'll start off with our first question, and that is, what is the most common COVID therapeutic agent you have seen prescribed in your area? And do you see the administration of the IV antiviral? And the last part of that question is, what % of your nursing homes are getting COVID therapeutics?
So COVID remains within our facilities, but thankfully more at an endemic rather than pandemic stage. As a result, our approach in our Johns Hopkins Medicine Collaborative for post-acute facilities, skilled nursing facilities, and assisted living facilities is to make the diagnosis as rapidly as possible and to implement Paxlovid therapy as quickly as possible, and certainly within the 5 days of symptomatic COVID. But in that regard, symptoms are an educational process because we're all familiar with fever, upper respiratory symptoms, but some of our older adults may develop a change in cognitive function, delirium, and there may be GI symptoms as well to consider. But our goal is to make that diagnosis to consider whether it is COVID or it is our other treatable viral illness this time of year, influenza, and then to get the appropriate medication. In the case of COVID, the number one medication for our facilities is Paxlovid, and within 5 days of symptom onset.
Along those same lines, do you have a policy to ensure that the COVID therapeutic agents are administered within that 5-day window of symptom onset?
Yes, our facilities have those policies, and we have, very importantly, educational programs that are interdisciplinary. So our consulting pharmacists are a key part in having access to those medications immediately available when appropriate, and that our nurses are appropriately trained in administering these medications. Our medical providers are aware that the medications are available, and that we have communication tools so that the symptoms are relayed, testing for COVID is done timely, and implementation of medications, therapeutics is done timely. So everybody has a role, including our nurse aides, who are our eyes and ears for the changes in our residents. Those early symptoms are often identified first by the nursing assistants.
In your practice, should everyone, even those with a mild COVID case, be treated with COVID therapeutics in the nursing home assisted living settings?
The answer is yes. And the reason for that is the underlying comorbidities and ages of the populations we serve in assisted living and skilled nursing facilities. So age is our first factor, but for even young adults who are receiving care in these settings, they often have the medical diagnoses, whether they be asthma, emphysema, whether it be cardiovascular disease, but there are a whole host of chronic conditions, diabetes. All of those conditions predispose even younger adults to complications and hospitalizations of COVID. So in general, there's a medical reason why an adult is receiving care in either assisted living or skilled nursing facility, and that underlying medical reason is the reason why Paxlovid therapy should be implemented when COVID is diagnosed.
So I want to go back just one more question I had asked you earlier, and that was what percentage of patients within the Johns Hopkins Collaborative that are COVID positive receive COVID therapeutics?
Well, I'd like to think it's 100%, but to be honest with you, I do not have that number today. However, I think it's a very important number for us to obtain, and we'll be looking at that. But certainly in our educational programs in our collaborative, we've emphasized the importance. And many of our programs have included nurse education, infection preventionists that are trained to recognize those symptoms and train the staff of the nursing facility. And very importantly, outreach to the family members of our residents so that they are aware of these policies and best practices for implementing medication therapy for active COVID disease.
Thank you. Now I'm going to switch up a little and talk about the bivalent vaccine. What is your current vaccination rate for COVID bivalent vaccine for residents and staff in your collaborative?
Most of our facilities for the residents are very high. There are some pockets that are not, but many of our facilities are at 90%. Our staff, however, are under 50%. And so a real concern to us is educating staff. Many younger adults feel that, well, it's now part of life. I've survived so far. I may well have had COVID before, but it's an educational process to understand the virus changes. The more immunity we have through vaccination of our younger adults, and particularly younger adults providing care to our nursing home and assisted living residents, the less these more vulnerable older adults will be in contracting the disease. So it really is education to our younger adults in the community, their role in protecting the more vulnerable. Same processes we've had, same educational programs we've had for influenza, but we've been challenged with our workforce in meeting the vaccination for herd immunity.
So what specific initiatives have you put in place to increase the rates of bivalent vaccine rates in your nursing home residents and staff?
I've participated in some town hall meetings where we've invited the family members, and particularly in the assisted living setting, to educate them on the importance, because they can be advocates for their loved ones in living within the facilities, to encourage staff, and then educating staff, and through various means. Huddles are very effective where there's more one-on-one education by an infection preventionist with the staff of the facility, talking about what are the barriers for them to be vaccinated. Barriers such as availability for the vaccine are gone. Facilities have the vaccine. Making time for the staff to be vaccinated, something that most facilities have incorporated into their HR policies. And even allowing time away from the facility should there be a vaccine reaction such as fever, myalgia, muscle aches, that a staff member is not punished for receiving a vaccine and then needing a day off because of their symptoms. So I've seen all of those strategies employed successfully, but the one-on-one, peer-to-peer answering questions and with facts is most helpful.
Are you aware of any vaccine access issues in your area for nursing homes or assisted living? And how has your medical team been instrumental in locating vaccine and connecting with local agencies?
We in this area have done a beautiful job of making vaccine available to the most vulnerable, those in assisted living and nursing facilities. So access to vaccine is not an issue, and done very effectively through our consulting pharmacies. So long-term care facilities all have contracts with pharmacies, they have the vaccine and have made those available to our residents and our staff. And that is a very effective means of making vaccine accessible.
What advice do you have for other medical directors receiving questions on the safety of the vaccine, and specifically the look at stroke risk in those greater than 65? That's in the news and on the internet.
Life is full of risk, and so our approaches are not to eliminate all risk, but to mitigate risk and to assess the benefits versus risks of any intervention that we offer to ourselves or to our residents and to our staff. In the case of COVID illness, we have data to show that vaccine prevents serious illness in all age groups now. And serious illness includes hospitalization and it includes death. And those who have chronic medical conditions even more so. So medical directors need to be upfront and visible and calmly stating these facts to their residents, to their family members in their family council meetings, and to the staff on the units, and to the leadership of the facility. And that's where visibility makes a difference. And the most successful facilities have had strong leadership from their administrators, their medical directors, and their directors of nursing, all together with one message, loud and clear. We have the tools to reduce COVID illness amongst our residents, but it starts with our staff and their vaccinations.
Excellent answer to that one. That's a tough one. So how do you address the topic of waning immunity with residents and their family? Like, for instance, someone who says, I just had a mild COVID infection. Why do I need the bivalent vaccine?
Data has shown that vaccination is more effective than the actual illness in preventing another bout of illness. And now that we are 3 years into the pandemic, we're seeing recurrent illnesses and changes in the virus strains. And again, we've learned so much about influenza virus and the fact that we need new vaccines every year to protect us against the new strains. So it shouldn't be a surprise to us that the coronavirus does mutate, does change. And the way to minimize that is by being up to date with vaccinations as they become available to us. We're accustomed to this once a year in the fall. Will that be the right strategy for coronavirus? We don't know the answer to that yet, but great research is happening. And I'm so proud of our researchers at Johns Hopkins who are leading the charges here and giving us that information. We in the clinical realm, we should be advocating that we follow, we put in place policies and procedures, and we act on these recommendations as they emerge. So I've tried to educate everyone. The change will happen. Policies will change. Vaccines will change. We have one goal: to reduce the illness amongst our residents and our staff. And we do so by being informed by new research, and we act on that research. So we in the trenches need to act when appropriately, but our recommendations today may well be different in 6 months, in 1 year, but let's stay abreast of those changes.
How do you address residents who ask the question, I'm up to date on my vaccines, but yet I still tested positive for COVID?
Nothing's 100% in life. We do lots of preventive measures to prevent cardiovascular disease. We have a low cholesterol diet. We exercise. All of those strategies reduce the risk of heart attacks and strokes, but they don't eliminate them. And the vaccines will not eliminate all infections, but they, in general, make those infections less severe. So what might be a day or two of feeling pretty crummy, but you're not so sick that you're in a hospital setting or you're in a respirator. What we saw, even with young, healthy adults in March and April of 2020, and all of us here at Johns Hopkins had to pitch in, roll up our sleeves, put on our scrub suits, put on our personal protective equipment, and care for all ages of active COVID disease because of the numbers who were so ill. Now it's business as usual. It's one of many illnesses that bring people to a hospital, but in general, those who come to the hospital are because they were not vaccinated or are not up to date with the new bivalent vaccine that's addressing the current strains in our community.
All right, I think you sort of touched on this one, but I want to just go into maybe a little bit more detail. And I wanted to know, will you and your colleagues at Johns Hopkins be implementing the new CDC recommendations for routine COVID vaccinations then going forward?
The CDC is our source of clinical truth. These are objective scientists, clinicians who evaluate the breadth of research and evaluate the epidemiology of infections and the severity of infections, and they make policies appropriate for our communities and our various communities. So CDC recommendations may differ in a nursing home than in a business setting or a community setting. But it's our job in the healthcare industry, and particularly in our settings of assisted living and skilled nursing facility, that we follow the CDC, their updated recommendations, and we implement them within our setting of care. And they're very specific in the settings of care. So every facility has an infection preventionist. That individual needs to be on that CDC website routinely. And I would say at least twice a week, Monday and Friday, but certainly needs to be abreast of changes and then developing with the leadership of the facility and including the family council and resident council in actively making the changes to be in compliance with CDC recommendations.
Thank you. And I have one last question. I wanted to know if Dr. Bellantoni, if you could share maybe a pearl to other medical directors who are tackling vaccine fatigue among their staff, their residents, everyone. What tip would you give to them?
Champions. Within our facilities, there are leaders. The nursing assistant who says, I got my vaccine. I made sure mom had her vaccine. I care about my residents and I know this is what I need to do. That person speaking to the nursing assistant, helping them change a bed, assist a resident, that one-on-one means so much. We are people, we have social skills, and we respond to that human element, sometimes more so than we do to the data that comes out in masses. And particularly when data are conflicting. And so it's hard to figure out, well, what's the truth of all this? At this time, we have enough information to know vaccine is safe and effective. And what we need are the champions in our facility at all levels, leadership certainly, but those in the trenches who can champion the practices of vaccination for staff and residents. That makes a huge difference. And the most successful facilities have had wonderful leadership, wonderful access through their pharmacies, but most importantly, engaged staff make a difference.
Thank you for joining us today, Dr. Bellantoni, and thank you, listeners. To learn more about this topic or to find out more about the IPRO QIN-QIO, please visit qi.ipro.org. Once again, thank you, Dr. Bellantoni, for sharing your expertise with us. We appreciate it.
Thank you for having me, and thank you for the wonderful work that the QIs do to support the care we're all providing. Have a good day.